Welcome to the NeoFOCUS-UK Education Group webinar series.
Hello, everyone. My name is Dr. Young. I'm one of the consultant neonatologists, part of the NeoFOCUS education program. Welcome to this NeoFOCUS webinar on the phenotypes of hemodynamic instability. We are very fortunate to have Professor Yasser Elsayed here with us today. He is an eminent professor of pediatrics at the University of Manitoba. He is also a staff neonatologist, registered echocardiologist, and also the founder of POCUS Neo, the chair of International POCUS Neo, and a director of the Integrated Hemodynamics Program. Dr. Bikash and Dr. Mahmoud Montasser are both going to be moderating the session. Thank you, Professor Elsayed, for joining us. Please post any questions in the Q&A and those will be answered in due course. There'll be a feedback link as well at the end of the talk. Thank you.
Wonderful. Thank you very much, Dr. Jean, Dr. Mahmoud, and Dr. Bikash for the kind invitation to this wonderful platform. I believe this is the second time to present on this wonderful platform. And today I have one of my topics that I actually like to present, and each time I present, I try to make some changes. So I presented this topic many times in different workshops and conferences, including the conference in Glasgow 2 years ago. But like you realize some changes or new ideas in the presentation. So I'm talking about phenotypes of hemodynamic instability. And I like to call objectives a promise. So I do my best, like for every one of you, to be at the end of this presentation, be able to answer three main questions. First, what are the fundamentals of hemodynamics? So even if you are new in the field of hemodynamics and you would like to get basics, I will share with you the basics fundamentals of hemodynamics in general. And then we are now in the era of precision-based management. We are moving from pure evidence-based medicine era, after we now understand the limitation of applying just pure evidence, assuming that everyone is the same. Now we are in the era of precision-based medicine. Everyone is different, especially when you're talking about complex diseases or complex physiology like hemodynamics. And then what are the physiologic phenotypes of hemodynamic instability and how to manage these phenotypes with some case scenarios. So I will try to do my best to finish this comprehensive three objectives in about 40 minutes. So we are talking about precision medicine. So let us just go over the definition of the precision medicine and what's the relation of this new introduced concept to hemodynamics or physiology-oriented practice in general. So precision medicine refers to clinical approach that moves beyond generalized treatment protocols. It means that in evidence-based medicine, you randomize 100 patients or 100 subjects, 50 to placebo and 50 to intervention, assuming that everyone is the same, which is not the case in all of the diseases. Everyone is not the same in everything. Maybe in some simple conditions like surfactant deficiency, we give surfactant antenatal steroids because it's like a very broad kind of physiology or benefit from steroids to be given for mothers with premature labor. That's okay, strong evidence, but it's not the same condition when you are talking about hemodynamics, pulmonary hypertension, or PDA management. So emphasizes individualized physiologic-oriented care based on each neonate or patient in general, specific phenotype, understanding pathophysiology, also genetic dynamic monitoring data. That's why hemodynamics is kind of point of care. It's not the echo or ultrasound done by someone coming from outside the unit and he doesn't know the details of the clinical information. Should be the neonatologist or intensive care physician, the one who's performing ultrasound and integrating that into cardiorespiratory monitoring. That's why we are using the concept integrated hemodynamics, because we are integrating the echo to the other monitoring, other clinical details, not just evaluating the echo separate from the clinical context. So just to make it simpler to you, if we start with this question, you have a clinical problem that you would like to solve at the bedside. So to understand if this can be answered by strong evidence or if this is related to precision-based medicine, you can ask this question: should I apply this intervention or perform this investigation to this patient? For example, should I apply or should I give norepinephrine or dopamine for this patient who's hypotension, for example? So if your answer is yes, I should, and everyone agree with you, this is a strong evidence, not personalized. A simple example, give surfactant to RDS. No one will argue with you. Give antenatal steroids to any pregnant woman who's premature labor. Or give caffeine for premature infants in 28 weeks. No one will argue with you about that because the evidence is really strong. But if the answer is, your answer is, it depends, or it depends on the phenotype or the underlying consequences, then it is not pure evidence. It is phenotypical application or personalized or precision-based medicine. So there is not enough evidence for generalized approach in this condition, then it is personalized precision, not a pure evidence. Typically, for the last 40 years of applying evidence, we know that applying certain things is good for outcome, very certain things. Antenatal steroid, cooling for HIE, CPAP compared to invasive ventilation, and caffeine for apnea prematurity, almost nothing else. But we know that cardiovascular drugs is a sign of worsening outcomes. That's why we should use these drugs very cautiously. Before applying any intervention, ask what the ultimate benefit is. So we are giving a medication or intervention, general in medicine, not only in neonate, in pediatric, and adults. There is two things that you are focusing on: maintain a positive metabolic rate to promote growth, or maintain balanced metabolic rate even in adult. Number two, which is important in hemodynamics, maintain tissue needs of oxygen, and the full stop. If your intervention doesn't improve oxygen consumption and delivery, then it is dangerous intervention, not helpful. So it is about oxygen delivery-based management if you are talking about hemodynamics. So precision-based medicine is a medicine of phenotypes. And how many phenotypes that we can describe? We have 4 different categories of phenotypes. Etiological phenotypes. I will give you example. Respiratory distress. Infant with tachypnea and grunting can be due to surfactant deficiency in breather, which is HMD, or surfactant deactivation with excess water, like in pulmonary edema, TTN, or pneumonia, etc. The presentation is the same, but they are different etiologies. We give surfactant probably for most of them, but the etiology is different. So that's etiological phenotype in one clinical condition, which is respiratory distress. But this physiological phenotype, RDS can be severe. Like there is 6 different phenotypes of RDS. There's 4 different phenotypes of TTN. And each one of them presented in a different way. And presented in a relation to physiological severity. Is it VQ mismatch, thickening of alveolar capillary membrane due to edema or hypoventilation, and etc. So that's a physiologic phenotype. or the physiologic phenotype related to the mechanism of hypoxemia and related to respiratory distress. And then the clinical phenotype is more broad description of the severity. So TTN, for example, has 4 phenotypes. The classic TTN, there is a moderate TTN, severe TTN, which we need to give surfactant in TTN, and there is malignant TTN when it is associated with pulmonary hypertension. So these are the clinical different phenotypes. And then therapeutic phenotypes, what category of medication that you would like to give. For example, in hypotension, you may need to give vasopressor or vasodilator or inotropic drug. So you need to select based on the physiology. So this is just summary, like this slide is summary of management based on precision and phenotypes. So now let us talk about instability of systemic circulation. Now we'll start talking about our topic for today. So etiological phenotypes of systemic circulation related instability, because we have pulmonary circulation related instability. It's not everything about BPHN and pulmonary hypertension. It could be pulmonary low flow or hypotension, or could be pulmonary congestion. So pulmonary abnormal circulation or instabilities may have multiple phenotypes, and some of them can be treated with nitric oxide, some of them nitric oxide is contraindicated. The same for systemic circulation. We have multiple etiologies. So I'm talking about etiology. So we have the 12 different, I summarized 12 different main etiologic phenotypes. Could be inflammatory. Remember, I'm talking about etiology now, not the physiology, not the physiologic phenotypes. So inflammatory could be sepsis or neck, suprarenal dysfunction, especially in premature infant or HIE, hypoxic ischemic etiology, high vascular resistance, like in cooling, which we call it vasoconstrictor physiology, hypovolemia, or could be iatrogenic. You guys, like with abuse of cardiovascular drugs, you may make systemic circulation instability by using abuse of cardiovascular drugs, especially in the troops. Could be pulmonary hypertension, arrhythmia, pH extremes, because with the acidic pH, you have vasodilation. With the alkalotic pH, you have vasoconstriction. Cardiac tamponade with high MAP, pericardial effusion, or could be cardiomyopathy, either genetic cardiomyopathy or viral cardiomyopathy, and left heart obstructive diseases. So these are the 12, and then in the comment, if you have any more that I like important category that I missed, let me know. So now we'll move to the physiologic phenotypes of systemic shock. And shock, by definition, it is decompensation, because you may have systemic circulation instability compensated, and you don't have to do anything. The body can compensate with certain mechanisms like tachycardia or vasoconstriction, and you may have the blood pressure, cardiac, what's still within normal, so you don't have to do anything. So we're talking about decompensated physiologic phenotypes of systemic shock. So it can be vasodilatory physiology, vasoconstrictor physiology. I'm talking about physiology now because we'll understand later that this could be a helpful physiology for the body to compensate. In extreme cases, can be decompensatory. For each one of them, can be compensatory or compensated physiology, or can be decompensated physiology. For example, vasoconstrictor can maintain the blood pressure within normal and can get the systemic circulation maintained. But with severe vasoconstriction, then the left heart will be in strain, and then the cardiac output will be decreased. So this is decompensated. And then cardiogenic shock, which is usually decompensated, hypovolemic shock, and then left-right shunt physiology, obstructive shock, typically coarctation or left hypoplastic heart, and then the restrictive physiology, when the heart is restricted by pericardial effusion or high mean air pressure. So these are the, as you can see, the 7 main phenotypes. For each one of them, simply, just I'll tell you a very simple secret. If you're still a beginner in hemodynamics, at the end of assessment of hemodynamics, we need to answer 4 things about systemic circulation the resistance and the flow, which one is high, which one is low or normal. Pulmonary circulation, two things, resistance and the flow, which one is high, normal or low. At the end, I have very good image about the phenotypes. So systemic blood flow or can be a blood flow or resistance. They are both important to maintain normal circulation. So systemic blood flow can be high. It can be high in hypertension if it is high in the arterial side, or congestive heart failure if the flow is high in the venous side. Or systemic blood flow can be low, and low typically in hypotension. Systemic vascular resistance can be high in vasoconstrictive physiology or can be low, typically in vasodilatory. And then pulmonary blood flow can be high in pulmonary congestion or can be low in pulmonary hypotension. That's probably interesting terminology to you, but it might happen. The pulmonary blood flow might be very low. Very simple example, when you have the infant born with RV hypertrophy due to premature closure of the PDA, the pulmonary blood flow expected to be very low. And then pulmonary vascular resistance can be high in typical pulmonary hypertension like PPHN, one of the phenotypes, or can be low. And can be low, which is kind of rare because pulmonary vascular resistance is physiologically low. But you may have it low when you give unnecessary nitric oxide in infant who's already low pulmonary blood flow. So you may cause more harm by doing that. So now we'll move to the clinical phenotypes. So you need to investigate in steps, like be systematic to define etiological phenotype, physiological phenotype, severity and compensation, mild, moderate, severe, with aerobic or anaerobic metabolism, and the degree of combined oxygen delivery. And simply, we can estimate the oxygen delivery if you calculate cardiac output and multiply by hemoglobin, multiply by oxygen saturation, you'll get the estimated oxygen delivery, which is 20 to 40 ml per kg per minute. If you have oxygen delivery less than 10 or single digit, this is at high risk of anaerobic metabolism. So then formulate a precise physiologic-based medical recommendation. If you do these steps, then you reach at the end easy if there is physiologic-based medical recommendation. How to do that in steps? Check the vital sign values at the time of assessment and the trend over time. So when you look at the vital signs, not only the blood pressure, oxygen saturation, perfusion index, ambient temperature, heart rate, and look at the trend over time. If the trend is worsening by more than 20%, this is a significant worsening trend. And we developed AI applications to help you in that. And then you can add echocardiography to the AI applications, add nearest values, and then this AI integration can help you to final assessment of hemodynamics. And at the end, you will know that systemic blood flow, high, low, or normal, systemic vascular resistance, high, low, or normal, pulmonary blood flow, the same for each one of them, and pulmonary vascular resistance. These are the four things, 2 for systemic and 2 for pulmonary, flow and resistance, as simple as that. It is very simple, but not that easy when you need a lot of training to be able to assess all of these parameters. And then the check oxygen consumption and the delivery. So what are the clinical signs of shock? Like to make it straightforward, easy, low 1 or more of the blood pressure values, not only mean blood pressure anymore, less than 5th centile, or with decreasing trend, and the trend more than 20%, significant decreasing trend, more than 20% below the baseline. If you have decrease in the trend more than 20% in less than 1 hour, this infant is crashing. If you have decreasing in the trend within 24 hours, this is acute. If you have it within 3 days, subacute, but if you have it beyond that, it is more chronic. So you may have it crashing, acute, subacute, or chronic. And borderline blood pressure parameters, look at the diastolic and pulse pressure. These are the 2 main independent blood pressure variables. Mean blood pressure is calculated value, and also systolic blood pressure is calculated value. This is diastolic plus pulse pressure. And then you have to assess if there is any oliguria or lactic acidosis. Low blood pressure with decreasing trend with the cerebral oxygen saturation by NIRS. If you look at NIRS and you see the blood pressure trend is decreasing and the cerebral oxygen saturation parallel to it decreasing at the same time, this is ominous sign. It means that typically the cerebral blood flow is decreasing. So now we should understand that hypotension is not a disease. Hypotension is just a marker or a vital sign of compromised blood flow. Blood pressure might be compromised with low, normal, or high mean blood pressure. High mean blood pressure could be due to vasoconstrictor physiology, which again could be compensatory or be decompensated when the LV performance impaired. So don't look only at the mean blood pressure. So simply, the blood pressure start with the diastolic. There's a baseline blood pressure in systemic circulation. And the diastolic blood pressure simply reflects systemic vascular resistance and the blood volume. So any one of them decreased, then the diastolic blood pressure will be affected. Simply when you have left or right shunt in PDA, you may have the diastolic blood pressure low because of decreased volume, still due to stealing of blood. And vasodilatory physiology, you will see diastolic blood pressure dropped. And then the heart will contract to create a pressure above the diastolic blood pressure enough to eject out the stroke volume, which is the pulse pressure, not systolic blood pressure. The systolic function of the heart reflected on pulse pressure, not systolic blood pressure. So pulse pressure is equal to heart performance, which is pump action of the heart, and also it is a pressure needed to eject the stroke volume. Both of them, the systolic blood pressure and pulse pressure, equal to systolic blood pressure. So don't use systolic blood pressure as a surrogate marker for systolic function. Use a pulse pressure. And then let us discuss the three main categories among the seven. The vasodilatory physiology, you have low diastolic blood pressure, and pulse pressure should stay normal, but systolic will also decrease because it is reflecting also diastolic blood pressure. Stroke volume might increase because the heart might be hyperdynamic, and the heart rate might increase for compensation, and the calculated cardiac output might be increased. But if you calculate systemic vascular resistance, it will be low. And how to calculate systemic vascular resistance? The mean blood pressure divided by cardiac output. Normal between 150 to 200 millimeter mercury per liter per kg per minute. And if it's more than 250 or with increasing trend, then it is more significant. And you can see here the heart is hyperdynamic. That's infant with vasodilatory shock. As you can see here, the blood pressure trend is very helpful to diagnose it. So you can see the three lines of invasive blood pressure. The lower one is a diastolic, the top one is systolic, and the red area is a pulse pressure. Pulse pressure is maintained all over, but the systolic and the diastolic, both of them, they are parallel and trending down with maintained normal pulse pressure. So this is vasodilatory physiology. And after start of norepinephrine, immediately or just short time, because norepinephrine is short acting, you can see the blood pressure improved. So typically, or the etiology or etiologic scenarios can be septic shock, inflammatory conditions like NEC, late onset shock and preterm or suprarenal dysfunction, medications like morphine, anesthesia, or acidosis, respiratory or metabolic. Or it might happen in HIE because of loss of vascular tone or suprarenal dysfunction associated with HIE. The second type, you may have the trend of the diastolic blood pressure is increasing, and according to that, your pulse pressure is decreasing. Sorry. And the systolic blood pressure is low because it reflects the pulse pressure. So here the heart rate might increase for compensation, but the systemic vascular resistance is expected to be high. I have seen as more than 1,000 millimeter mercury per kg per minute. Again, the normal between 150 to 200, sometimes up to 250 in term infant. So the heart contracts against resistance, especially in premature infant or HIE. You will see the heart is compromised and impaired performance. But that's not in all situations. You may see vasoconstrictor physiology with maintained heart functions, especially in term infant. And vasoconstriction by itself is helpful to maintain the normal blood flow because the perfusion is typically dependent on mean blood pressure. So mean blood pressure in this situation is still normal. But if the vasoconstrictor physiology continued for a long time, then you may have it as shock, as decompensated. After a start of dobutamine or merinone, you can see the blood pressure dropped, but was widened pulse pressure, so improved the blood pressure. Typically, failure post-natal transition also is very common for premature infant born to a mother with preeclampsia, because preeclampsia, the heart contracts against resistance antenatally for a long time. Post-ED ligation, although we are not doing surgical ligation anymore, or very rare, like maybe one case every 2 years. Post-EV malformation embolization, because of sudden closure of the shunt, the body already vasoconstricted to compensate. So if you close the shunt immediately, the vasoconstriction will be more clinically evident and clear, and that might cause heart decompensation. Pulmonary hypertension, HIE, and then septic shock, although it is rare in neonate to have vasoconstrictor physiology in septic shock. It's more common in pediatric and adult. And then cardiogenic shock is much easier because you have everything is low, everything is bad, including all of the blood pressure values and cardiac output. And systemic vascular resistance usually low. And they have the heart now is poorly contracting. So that could be because of high resistance secondary to vasoconstrictor physiology, or could be intrinsic poor myocardial performance due cardiomyopathy. But in neonate, usually is secondary to high resistance. So you can see now that all of the blood pressure parameters is all of them are now collapsing and with very normal pressure. After the start of epinephrine, the blood pressure or pulse pressure widened and the blood pressure improved. On epinephrine in this case, because epinephrine is needed to support both the resistance in the solid blood pressure and also heart performance. It is common in low preload. In this situation, don't give epinephrine, you need to just give fluids. Failure of postnatal transition, adaptation, pulmonary hypertension, myocardial dysfunction, mechanical ventilation, progressive acidosis, or overdose of inotropes. So in this condition, you just treat the underlying cause. Overdose of inotropes, you need to stop them, nothing else. In progressive acidosis, you need to correct acidosis, either respiratory or metabolic. Mechanical ventilation just reduce the mean air pressure. So just to treat the underlying cause, not just to give epinephrine or inotrope to correct the condition. But what's the most common among them? The most common physiology in our data, when we analyzed for many years, we found that vasodilatory, and we published that already in one of our articles, vasodilatory shock is 80% of the cases. So that's why the most common medication used in neonatal hypotension now is norepinephrine. Typically, we are not using dopamine anymore. It is outdated medication because of so many side effects, and medication that's commonly associated with side effects, including high increase in the pulmonary vascular resistance and the myocardial consumption of oxygen. We are using dopamine when we have a PDA left-right shunt with shock. For example, septic shock or hypotension when the PDA left-right shunt. So we are using the dopamine for the side effect to increase the pulmonary vascular resistance and limit the shunt. Otherwise, we're using norepinephrine or in extreme situation, vasopressin. But you have 20% of the cases and you need to do TN echo. For the 80% of the cases, you may rely on assessment of the blood pressure physiology and the trend. Because normal pulse pressure will reassure you that the heart performance is okay. You can do echo just to reassure you that you are not missing a shunt or anything else. But you can start the treatment as a vasopressor based on the clinical assessment. But in the 20% of the cases, when you have normal pulse pressure due to vasoconstrictor physiology, cardiogenic shock, hypovolemia, left-right shunt, or restrictive physiology, you need to do TN echo. So simply for the three main phenotypes, you have a vasodilatory physiology, use norepinephrine or vasopressin, plus minus fluids if needed, only if indicated, if there is evidence of hypovolemia. And then in vasoconstrictor physiology, when you have normal pulse pressure, but trending higher the systolic pressure, do betamine or Merinone, and use Merinone cautiously. Don't use it in very premature infant without having expert in hemodynamics, because it might drop the blood pressure significantly and half-life is long. And also don't use it in HIE, severe HIE, because again, the metabolism is expected to be impaired by the liver and excretion by kidney in HIE. So half-life is expected to be 6 to 8 hours, but in HIE might be few days. So safer to use dobutamine because of shorter half-life. And it can be cardiogenic shock, and typically be sure that there is no hypovolemia, so you may need to give fluids, and then consider epinephrine. Blood pressure trend is very important. This is a 22 weeks gestational age. And if you look at the blood pressure here, the team recognized this as low blood pressure. It was, I think, it was 31 over 16 or 15, and the mean was 23. So this infant was given bolus of normal saline unnecessarily, and you can see here jump of the blood pressure, which might happen also with the agitation or stimulation. This by itself is enough to induce IVH. But you have reassuring trend. So when you have reassuring trend, with normal NIRS, we are using NIRS as a routine for premature infants for the first 3 days of life. So if you have normal NIRS trend and normal blood pressure trend, you don't have to do anything. And even if you have trend low of NIRS, you need to check the blood gas because it could be low CO2, not related to the blood pressure. And again, we are using also transcutaneous CO2 monitoring in premature infants now. If you don't have invasive blood pressure available, or you tried and there is no chance to insert an arterial line, adjust the monitor to measure the blood pressure every 10 to 15 minutes. I'm talking about infant really critical and you would like to get a trend. So if you do that, the machine will, or the monitor will measure the blood pressure every 10 to 15 minutes, and you can look at the trend. You can draw a line on the top trend, and you can see the systolic blood pressure trending down, and the same for the systolic. So that's consistent with the vasodilatory shock. And I think here after the start of medication, so you can see the blood pressure now started to improve. So this is a case scenario here. And this case scenario, you can notice many things. So if you look at the blood pressure at this time, 28 over 19, there's a 25 weeks, and mean blood pressure is 23. And this infant 6 hours old. If you check this blood pressure on the our AI calculator for the blood pressure, you'll realize that this blood pressure is still above the 5th centile. But you have other things here. You have pulses alternans, which is abnormal, and you have the blood pressure measured by cuff. So like almost 1 or 2 hours before the blood pressure here. So you can notice that the pulse pressure was wide and then became narrow. So that's trending narrowing of the pulse pressure. And that's explaining why there's pulses alternans. Echo, in this case, was as you can see here. So echo showed a poor myocardial performance, and there's tachycardia up to 200, but the heart was not contracting well. I'll just show the video quicker. And there was actually air impulse at the pulmonary outflow, but not obstructive. And the PDA in this, and also you can see here in the MM mode, the anterior wall of the right ventricle is not contracting well. And also the posterior wall of the left ventricle is flat. And the calculated fraction shortening was, I think, 18. And here you have the PDA, huge PDA, right-left shunt. If you assess this echocardiography, this right-left shunt, your right-left shunt PDA, away from the clinical context, you may consider this infant might have BPHN, and you may start nitric oxide. And if you do so, this infant may die. If you start nitric oxide in this condition, infant may die. So go back here and then let us understand what happened. This infant with poor myocardial performance, the blood pressure is still normal because the blood pressure is through the UAC, and UAC is postductal. So the pressure reaching the tip catheter here is the postductal blood. So it is added blood from the PDA right left shunt. So the PDA in this case is supporting the systemic circulation. This infant was 25 FiO2. So there is no clinical signs of pulmonary hypertension, and also the septum was not flattened. So not every PDA right left shunt is BPHN. It could be perfusing systemic circulation. This infant also had the impaired filling of the left ventricle. So given fluids and given just 5 mics of dobutamine, and that was enough to improve this infant within 2 hours. But if you're not understanding the physiology, or you have one of the colleagues from cardiology reviewed the echo away from the clinical context, it might be misinterpreted as BPHN. And it happens. I have seen that. So if you analyze now according to our phenotypical table, so etiological phenotype here, postnatal transition failure due to maternal preeclampsia. So this infant born to mother with preeclampsia, explaining this high systemic vascular resistance. Estimated when we calculated systemic vascular resistance was actually more than 300 millimeter mercury. So it is vasoconstrictor secondary to hypovolemia, empty left ventricle, and systemic blood flow is low, systemic vascular resistance high, and there is no issue with pulmonary circulation. So the PDA was supporting systemic circulation this time. The clinical phenotype here, we have low cardiac output, low cerebral blood flow, presented on NIRS with impaired autoregulation, and there was anaerobic metabolism. The lactic acid was 5 millimole per liter. So therapeutic phenotype here, this infant was just given 10 ml per kg fluid to fill the left ventricle and 5 mics of dobutamine. And this infant, the blood pressure, everything improved, and I think probably 2 hours. And the dobutamine was discontinued in 6 hours. It did not even continue overnight. So I have another case here to just clarify the same concept. We have infant with HIE on cooling protocol with low blood pressure, but with maintained pulse pressure. I just go over this case quickly because we discussed already this physiology, this vasodilatory physiology, and it's very easy to manage. Vasopressor is enough to correct the condition. You have normal pulse pressure. So the trend of the blood pressure decreased over time, but with maintained pulse pressure. And the near-field spectroscopy trend also decreased, also stayed within acceptable limit. So here it is vasodilatory physiology with low systemic blood flow, low systemic vascular resistance, but normal pulmonary blood flow, normal pulmonary vascular resistance. If you just keep yourself minded about these 4 categories of the hemodynamic circulation for systemic and pulmonary, then you will not miss anything. You have to define what is the systemic blood flow, what is systemic vascular resistance, the pulmonary blood flow, and pulmonary vascular resistance. Okay, another case here, which is also very easy, straightforward, IDM with hypoglycemia. And here you have the blood pressure 51/45. So you have narrow pulse pressure with oliguria, and you have the for a chamber view with almost empty heart with severe hypertrophy, underfilling. You don't have to go anything other than fluid and beta blocker. Sometimes the beta blockers slow the heart rate and give more time for filling. But what is the worst? The blood pressure might drop and this infant might be hypotensive. Never ever give any troop in this case. This infant usually compensated, as you can see here, by vasoconstrictor physiology. Again, I'm reminding you that vasoconstrictor physiology is not always bad. It is a compensation, and usually compensating for low systemic blood flow, especially in hypovolemia. So when it happens, it is helpful. So when the situation is really bad, you need to support it. So what is the medication to support? Here is vasopressor. If the vasoconstrictor physiology lost, give vasopressor. Don't give vasodilator or any trope in this case. So we have a etiologic phenotype IDM, physiologic phenotype hypertrophic cardiomyopathy with low systemic blood flow, high systemic vascular resistance, and the pulmonary blood flow could be low because also you have the right side low flow, and then pulmonary vascular resistance, it is usually normal in this case. So it is forbidden to give nitric oxide because now you have the pulmonary blood flow dependent on the physiologic pulmonary vascular resistance. If you drop the pulmonary vascular resistance by giving nitric oxide, then you may give severe hypoxemia because the pulmonary blood flow is already low, and you may lower the pulmonary artery pressure more if you start the pulmonary vasodilator. So having this scheme of arrangement will make you really easy to understand what is the issue in the physiology, what you need to avoid at the same time. The clinical phenotype here is low cardiac output with oliguria, and then the therapeutic phenotype, fluid with beta blocker. So another case scenario here, just to remind you, when you have a shock infant who's initially stable and then crashed. So infant was stable with mom for 1 or 2 days and then crashed with shock. And you may see pre and post ductal saturation difference. The first thing that you need to do without hesitation to start the prostaglandin. And don't ever start nitric oxide assuming this BPHN because of pre and post ductal saturation difference. This case, usually it is either shock with low systemic blood flow, dependent on duct, or it could be coarctation or any ductal bindal lesion, and prostaglandin might be life-saving in this condition. In relation to blood pressure centile values, already published our centile values, but it is already included on our website, neobeats.academy, as AI calculator. So the trend is the most important. Now we understand the value of looking at the trend. So trend of the diastolic blood pressure, pulse pressure, systemic vascular resistance, cardiac output, and vasodilatory shock. You have low trend of diastolic blood pressure, normal pulse pressure, low systemic vascular resistance, and normal to high trend of cardiac output. So it could be within normal, but it is about the trend. So the trend, but you may have the value still within the 5th to 95th centile. But the trend is the key to know what's going on. So you need to have 2 points of assessment. When the infant was stable, few hours ago or few minutes ago, according to is it crash or acute or subacute, just 2 points of assessment, the baseline and the trend over time. Vasoconstrictor physiology, you have higher trend of diastolic blood pressure and calculated systemic vascular resistance high, narrow pulse pressure, and low cardiac output. Cardiogenic shock, everything is low. Left-right shunt, you have wide pulse pressure with low diastolic blood pressure and high cardiac output from the left ventricle. Systemic vascular resistance is usually low because of low diastolic blood pressure. And the volume depletion, usually the body will compensate by maintaining the normal diastolic blood pressure or even increased. And this is more mature in term infant and in children, not very mature in preterm infant. That's why premature infants, they have more tendency of hypotension due to hypovolemia because they don't have the capacity to vasoconstrict for compensation, the same like term. Low cardiac output is expected in volume depletion, and then again systemic vascular resistance to compensate, which again more common in term more than in preterm. Obstructive physiology is when you have obstruction, typically the pulse pressure is expected to be narrow. For example, coarctation of aorta and low cardiac output, and systemic vascular resistance at least normal. Restrictive physiology, you have normal diastolic blood pressure, pulse pressure low normal, cardiac output low normal, and systemic vascular resistance usually within normal. So this is a trend, already published that in one of our articles. I will show you the article if you'd like to read it in details. The therapeutic phenotypes is very simple, straightforward. Vasopressor to be given a vasodilatory physiology, and vasopressor, or epinephrine. In a troop plus vasopressor effect, Dopamine, as I mentioned, only indicated if you have left-right shunt, but otherwise use epinephrine. Or in severe vasodilatory physiology, you can use also epinephrine because it's stronger. In electro plus vasodilator and vasoconstrictor decompensated physiology or cardiogenic shock. And cardiogenic shock, if there's hypotension, sometimes you are using combination dobutamine plus norepinephrine, because in cardiogenic shock you have also low diastolic blood pressure. Fluids only if there is hypovolemia. And keep in mind, and when you use any inotropes or vasopressor, you start with the lowest dose, and when you reach moderate dose without effect, it could be suprarenal dysfunction. Suprarenal gland is one of the organs in the body, and when you have shock, the suprarenal gland will be hypoperfused. So steroids will not be released as expected. So that's why it is very common to give steroids to support the expected associated suprarenal dysfunction. And I will not go over these slides in details, but I can share it with you if you like. We have this titration available at the bedside for the in-house staff and the nurses when you have any norepinephrine or any medication started. And we would like to wean the medication where this titration schema, so they don't have to come back to us at each step they need to wean. So you can go up in stepwise according to the half-life of the medication, or you can wean, titrate down in this specific manner. And the same for dobutamine, vasopressin, according to the half-life. So vasopressin longer half-life, so you need to step up by 30 to 60 minutes. Merinon is longer half-life, so you need to step up by 2 to 3 hours, and also when you wean slower. Epinephrine, it is short half-life, so it is 15 to 30 minutes. Titration up or titration down. Only write one statement, clear statement for the nurse, so she can titrate according to the centile values of the blood pressure, and write that very clear, what is acceptable centile values. So when we wean, we select not the 5th centile to wean, the 25th, a number between 5th and 25th centile. And that's also available on our AI calculator. So we'll give you what are the weaning parameters that you need to consider. The same for the vitamin, although it is very limited use now. And then just to show you here, this infant was very high dose of inotropes used. That was very long time ago, it was more than 10 years ago. I never seen this case again. This infant was very high dose of dobutamine, epinephrine, before the era of applied hemodynamics. And this infant was almost dying. After we studied inotropes, a different person improved. So inotropes that we are using can be killing to the infant, and discontinuation can be the life-saving. If you would like to read more about the physiologic-based integrated algorithm and management of hemodynamics, you can go through this article. And thank you very much. I hope that we have some time for questions. I took more than time.
Thank you, Prof. Yasser. So that was an incredibly interesting and thought-provoking talk. Thank you so much. So if anyone has any questions, please put them into the chat. Just hand over to Mahmoud and Bakash.
Thank you, Jean. Thanks, Yasser. That was an outstanding talk, as always. Very thought-provoking, and maybe we'll just wait for some questions, but we can have a chat about how do you think fundamentals of hemodynamics and physiology be implemented in day-to-day care in NICU?
Yeah, that's very good questions. For a long time, unfortunately, the concept of hemodynamics was a little bit like a complex. That was a start, unfortunately, in Canada, like 10 years ago, by the hemodynamics group. This is just restricted to certain people. They are in charge of this concept. But over time, we realized that every single neonatologist should understand the hemodynamics physiology because as I showed you, like 80% of the cases you can manage even before TMA echo when you look at the blood pressure in details and all of the vital signs and get a very good idea about the hemodynamics, even before you do echocardiography. Although echo is important in a lot of, like 20% of the cases, as I mentioned, at least. Or when you start the medication and there is no improvement, then we need to do an echocardiography. But the hemodynamics physiology is important. So we started teaching that to our in-house staff, all of the fellows and all of the in-house staff and our staff. I organized every certain period of time a session to orient them about the hemodynamics. And I converted educational memory cards, and also there is written guidelines available, not only for the physician, also for the nurses. We are teaching also nurses in the basics of hemodynamics, how to manage the blood pressure, how to log the blood pressure, and how to titrate. So the way that I showed you in titration slides, it's already available for the nurses and everyone in the unit. They can look at it. And also we created online course on our learning management system for all of the nurses, even RTs and physicians to finish. And it is integration between very basic and also more advanced. If anyone would like to get more advanced idea about hemodynamics, is also available. So education, very targeted education to everyone in the unit, including all of the bedside nurses. And then you should have very clear, stepwise algorithm management. When you have such things happening, what you need to do next, not leave it vague, or just to a person who is really good understanding of hemodynamics, he might not be available. So everything should be very clear, stepwise, and we like to help also an easier approach. We created our AI calculators, which is now available. We open to everyone. So you don't have any excuse in your cell phone. You can just enter the blood pressure and can give you immediately an idea about the trend. Also, not only the blood pressure now is abnormal or normal, you can enter and the calculator will let you know about the trend. Trend is normal or abnormal.
Thank you, Yasser, so much. Thank you for, I was having a similar question, Mahmood, so which you put it beautifully out there. Because I always feel that a lot of our colleagues who don't do echo, they think that hemodynamics is outside their remit. And what you have beautifully explained is that echo is just an adjuvant to the whole bigger picture of hemodynamics. They don't need to do an echo. There are so many other parameters which can be used to help them in decision making. So for similar clinicians, yes, sir. I just wanted to ask you, so which parameter or combination of markers would you suggest them so that they can initiate the cardiovascular support in a neonate who's not frankly hypotensive? So I know that we jump on hypotension and we have seen the era where we have started giving all those medications to a baby who's not frankly hypotensive. What are the parameters you suggest?
Okay, that's a very good question. So simply, we are teaching our colleagues that there is three blood pressure parameters are important. One of them, like two of them, they are important to diagnose the hemodynamic instability: the pulse pressure and the systolic blood pressure, and the trend of both of them. The mean blood pressure, once you have the infant stabilized and you are weaning everything, the mean blood pressure is important because it is the perfusion pressure. Or it is the pressure that really decide for the perfusion. But that's once you have everything normalized and you are weaning, you can now rely on the mean blood pressure. But pulse pressure and the diastolic blood pressure, that's for the blood pressure and the trend over time. Also, we created, now through the AI, I haven't shared that yet with anyone, we created an equation to extract the cardiac output and systemic vascular resistance from the blood pressure. So through equation, which I hopefully I will publish it soon, even if you don't have the echo done immediately, cannot be done immediately, or there is no one available, you can actually get the from the blood pressure calculated cardiac output and systemic vascular resistance, and can give you better idea about, and again, about the trend. You have to calculate it when the infant was stable and when the infant assumed to be unstable. And then the most sensitive organ for perfusion is the kidney. So look at the renal output over the last 24 hours or last 6 hours, it is more acute. And the blood gases for acidosis and lactic acidosis. And then the components of oxygen delivery, hemoglobin, oxygen saturation, and cardiac output. Again, if you don't have cardiac output by echo, you can use the non-invasive equation that I will share hopefully soon to calculate the oxygen delivery. So you can use from the blood pressure, and you just need the hemoglobin and the saturation. Can give you an idea if this infant requires transfusion. Because now we don't have any specific parameter to decide if the transfusion is needed or not. Simply when you have oxygen delivery outside normal range, because it's not only about the hemoglobin, it is associated saturation and associated also cardiac output. And saturation, not only saturation at the time, it is a trend. And the trend, we are using histograms. So for example, you have, we teach during round with the fellows, premature infant stable but chronic, and the hemoglobin is 80. 80 gram per liter.
Yeah.
So should you transfuse or not? They may say that this infant is chronic and stable, but look at the oxygen histograms. You have 20% of the time the oxygen saturation on the histogram less than the target. It means that you have 20% of the time, which 1% is 15 minutes. The oxygen delivery is much lower than the acceptable level. So this infant might not really get enough growth or enough maturation of the brain because of this issue. So when you calculate oxygen delivery, calculate on the oxygen histograms, and according to the different categories of the histogram. In the lower side, when the oxygen requirement, the saturation less than the target, you have significant drop in the oxygen delivery. In this situation, I will consider transfusion. Not just based on 80 is not really according to the guidelines, and the guidelines, as I mentioned, just generalized and not personalized. So might not fit for everyone. So it, like all of I mentioned at the end will target the oxygen delivery to get the oxygen delivery maintained, all of these vital signs. But you can, when I mention everything, almost everything I mentioned is important, and the echo is just one parameter. So don't just abstract hemodynamics in doing TN echo. That's one of the wrong concepts for a lot of our colleagues. TN echo can help you to answer a few questions, but you can get 80% or more of your questions, if not 100%, from your clinical assessment and the trend of all of these parameters. I did not mention in details the perfusion index, which is another parameter to reflect peripheral vasoconstriction. I did not mention multiple ways of indirect assessment of cardiac output because there is limitation in evidence supporting its use in neonate. Although now we made a new equation to calculate cardiac output from the blood pressure. So there is a lot of things, but I mentioned the important parameters that you have it in every day at the bedside from the monitor. The monitor, you have a treasure of information, physiological information. You need to spend 5 minutes in front of the monitor, and you can get the trend in 24 hours, histograms, and look at, correlate the trend of everything all together, the blood pressure together with the saturation, the other vital signs like respiratory rate, perfusion index. If you have near-field spectroscopy, that would be perfect. So we can get a very good physiologic idea about the trend over time without need to do echo for everyone, although it is important in a lot of cases.
Oh, thank you so much, Yasser. I think so we're running out of time. So there are a few questions. I think so if you can answer a few of the questions for the audience. One of the question asked by Mohammed Bahari is that, is there any evidence to suggest the TNE centers have better outcomes overall compared to those who don't?
Yeah, okay. And this question was asked many times ago. We did it in our unit. That's unethical now to randomize cases because now randomization cannot answer everything. You cannot randomize to actually personalize management with a good management for a group and then like random management for another group. That's unethical. But what we did, we've already published in multiple articles from our unit, the integrated hemodynamics compared to before the era of integrated hemodynamics. So we compared the two eras, the era before and the era after, and there was significant decreased trend of mortality. Non-significant because the number was small, but significant reduced time to clinical recovery. So the time to clinical recovery reduced to 30% out of the compared to the era before applying the hemodynamics. So again, it's not about T in echo. This is about the integrated hemodynamics. Understand the physiology. Forget about the T in echo as a technique, and just understand. If you understand the hemodynamics, how to assess the blood pressure, how to understand the physiology, and even if the echo done by cardiologist, but just to get the numbers and calculate it yourself, the other missing things, and correlated with the other hemodynamics parameters, that's enough. You don't have to do the technique yourself. Just to get from the cardiologist the numbers or ask for certain numbers not provided to do it for you, and then integrate to blood pressure and everything. So it is integrated hemodynamics, not T in echo. T in echo, as I mentioned, is needed for 20% of the cases, not all the 100%. But the integrated hemodynamics, it is about the physiology of hemodynamics. So it is the heart of precision medicine, which is now the era that we are applying at the bedside more and more. Just move away from generalized medicine to everyone, empirical, give epinephrine to everyone or dopamine to everyone, to more personalized according to the physiology, which makes sense. Assume that everyone is unique physiology and personalized based on the clinical data. Not just give random medication the same, assuming that everyone is the same.
Thanks, Yasser. I totally agree with you, and I don't think it's ethical anymore just to randomize babies to, regimented management versus personalized management. Just one last question, please. So there's a question about the influence of delayed cord clamping on hemodynamics, and for example, if there is a baby with HIE, would allowing delayed cord clamping help to reduce the inotropic support and myocardial injury?
Very good question, and was already answered by the guidelines. So the American Heart Association regarding the delayed cord clamping, there is a statement which I think I may have it in my cell phone. So the delayed cord clamping should be considered, especially in premature infants, is very helpful and very physiologic, but should not delay resuscitation if there is assumption that resuscitation is imminent and needed. And HIE is one of these indications. So if the infant born flat and known before birth there is fetal bradycardia, so delay 1 minute without resuscitation, that might be detrimental. So that's not supported for infant. So not supported to delay resuscitation. But what some centers usually, some centers consider now, you can start resuscitation while the cord is still connected. So if you're able to do that, that's fine. So start resuscitation while the cord is connected, and there is a special set of resuscitation at the delivery, beside or at the delivery table, and then do the resuscitation and keep the cord connected. That's still okay. Some centers are applying that, but it's not provided in most of the centers yet. So in HIE, especially when the infant's flat, don't delay resuscitation by doing the cord clamping.
Great. Thank you very much, Yasser. So Gina, will hand over to you for the closure. You're muted,
Gina.
So thank you so much for this fantastic session. I think we've gained a lot to take back to our clinical practice, and look forward to reading your publications and trying your AI apps, which is a great innovation. So thank you so much for sharing your knowledge with us. And this session will be recorded, it has been recorded and will be posted on our YouTube channel. There is a survey that people who are attending will get, and there'll be a certificate of attendance. Thanks very much, and thank you to Mahmood and Bikash as well for moderating.
Thank you so much, Jean, to yourself and the whole education team of NeoFOCUS for organizing such fantastic webinars and making us part of it. And thank you so much, Yasser.
Thank you. Thanks, Yasser.
Yeah, wonderful. Thank you very much, everyone. And it was really kind invitation again. So thank you, and hope to see you again in the future.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.